Thank you very much for the introduction, and I hope that you can see my slides, my desktop, because I just shared it. So I'm assuming that you'll tell me if there's a problem. So it's a real pleasure to be participating in this meeting. It's a really sad problem for the whole world that we are having to make adjustments because of the COVID-19 pandemic, and I think in the UK and also in Chile, you have had a difficult time. But one of the things that I think at least has maybe benefited is this sort of ability to do this type of remote lecture. So, I very much look forward to the time that I can actually visit Chile again and really enjoy the beautiful country and company of my friends there. But in the meantime, I will do my best to really talk about some of the new developments in systemic sclerosis, because it has been a very exciting time, I think, in the last few years. So what I want to do over the next few minutes is to, first of all, review the clinical burden of systemic sclerosis and really say that even despite the progress that has been made, we still have a large unmet medical need. I would then like to just take a little bit of time to talk about our current management of two of the main aspects of the disease, that is the skin fibrosis and the lung fibrosis, and really review the evidence base and how we have moved forward in our treatment of the condition generally, but again, how there is still more work to be done, and really that will lead into a discussion of some of the exciting emerging treatments and ongoing clinical trials for the disease. So systemic sclerosis is clinically diverse, and we can classify all of our patients, in fact, into one of two subgroups: those that have the diffuse form of the disease, where they have extensive thickening or fibrosis of the skin, shown here on the left. And the majority of our patients, at least in our center, that in fact have less severe skin fibrosis and would be classified as having limited disease, where the thickening of the skin is really more confined to the face, the neck, and the extremities. But there are a range of other complications of the disease, and I show them in this slide. And it is really a reminder that this truly is systemic sclerosis, well beyond just the problems that we see in the skin. And I've just highlighted here particularly the problems that our patients really tell us are a great burden to them. The digital vascular disease, the ischemia and the Raynaud's phenomenon, and we'll talk more about that in the second lecture. Gastrointestinal tract symptoms is a huge problem for our patients. Some aspects are relatively treatable, but others, such as pseudo-obstruction or intestinal failure or anorectal incontinence, can have an enormous impact on patients. And then the musculoskeletal involvement, the calcinosis, the contractures, the destruction of connective tissue in the digits. And this really is a big problem because it impacts so much on hand and upper limb function. So those are the problems that our patients are burdened with. But I think as physicians, we have understandably focused a little bit more on the life-threatening complications, because unfortunately, this is also a disease with a very high mortality, and around half of the patients that we see in our large center will ultimately die from their systemic sclerosis or from a complication of the disease. And that includes lung fibrosis, cardiac involvement, scleroderma renal crisis, which remains a challenge even though it is more treatable than it used to be, and pulmonary hypertension, which I would separate off a little bit because there are now quite a lot of treatment options for pulmonary hypertension, particularly pulmonary arterial hypertension, and this is an area of major progress, I would say, in the last 2 decades. But what we gain from sort of observing our large cohort of patients in London at the Royal Free Hospital is an understanding of what the timing and frequency of those different complications is, and when we need to be most vigilant for them. And you can see here in some data from a publication a few years ago now, that with diffuse scleroderma, about half of our patients will ultimately develop significant or severe lung fibrosis. This can take several years to develop. It's notable, though, that limited cutaneous patients will also have a high risk of developing lung fibrosis. Around a quarter of the patients with limited scleroderma will develop significant lung fibrosis. And So that means because limited disease is commoner, that overall lung fibrosis is pretty evenly split between those with limited and those with diffuse skin disease. For other complications, you can see that there's a much more even distribution. So the red line is the pulmonary hypertension frequency. And you can see this is a complication that can occur at any stage in follow-up. So you always need to be vigilant. And roughly 1 to 2% of our patients per year will develop pulmonary hypertension. And that is independent of whether it's diffuse or limited skin disease. But nevertheless, the skin subset does help us a little bit in planning treatment, because you can see some complications occur more frequently or earlier in those with diffuse disease. But the other tool that we have in our management to try and predict the future for our patients when they present with the disease are those antibodies that we use to diagnose systemic sclerosis. And I've put up a range of the antibodies here that we see that are all can be diagnostic of systemic sclerosis, but the most common and important antibodies are anti-centromere antibody, anti-SCL70, and anti-RNA polymerase 3. And what we've seen in our more recent analysis is that, in fact, the antibodies combined with the skin subset really allow us to quite accurately predict which patients are most at risk of the different complications. And we published a paper last year, which I think has been very helpful to scleroderma management, because it's really subgrouped our patients based on skin and antibody into different groups that allow us to sort of plan management accordingly. And here is just one figure taken from that publication, which shows quite how useful the anti-topoisomerase 1 or SCL70 antibody is in predicting those patients that are at high risk of getting lung fibrosis. Here you can see that independent of the skin subset, those two green lines represent those patients with an anti-SCL70 antibody from disease onset, the risk of developing significant lung fibrosis. And you can see that more than 80% of those patients will get lung fibrosis, and more than 3/4 within the first 3 to 5 years of disease. So these are certainly patients that we want to highlight when we're trying to identify and manage lung complications. So we have made progress in systemic sclerosis. Some of it has been incremental and some of it has been based on robust clinical trials. And we can now come up with evidence-based recommendations or guidelines around management. And we've published guidelines in the UK for systemic sclerosis, and there are also EULAR recommendations that are summarized here for each of the major complications of the disease. So it's certainly important to regard systemic sclerosis as treatable, if not curable, with a different level of effectiveness and evidence to support the treatments that we use. So what I'd like to do just over the next few slides is really talk about two major complications and really just review some of the evidence for the standard treatments that we use. So the first is that aspect of the disease that all patients have, and that is particularly a problem for those with diffuse cutaneous systemic sclerosis, and that is the skin fibrosis. And you can see in these clinical photographs what a difficult problem that is for severe patients. And in trying to treat this, we've really followed our rationale as rheumatologists in that this is an autoimmune disease. And so immunosuppression does at least give us an option to try and slow the progress. And we think that if we can intervene at the inflammatory phase of the disease in the skin with immune suppression, we can hopefully improve the longer term outcome. And the drugs and approaches that we have available to us are summarized here. These are the approaches that we would say are part of our standard practice now for patients with diffuse cutaneous systemic sclerosis: methotrexate, mycophenolate mofetil, cyclophosphamide, and sometimes very intense immunosuppression with an autologous stem cell transplant. And I'll specifically talk about that in a few slides' time. But the standard approaches of methotrexate, mycophenolate, and cyclophosphamide have really come into our standard of care, really, and we would say that all patients with early diffuse scleroderma should be considered for one of these drugs. But we, of course, need to know whether the treatments are working, and it is important that we have a standardized way to assess skin sclerosis in scleroderma, and we have, of course, the modified Rodnan skin score. So this is perhaps somewhat analogous to a tender and swollen joint count in arthritis, but for scleroderma, what we're trying to do is have a quantitation of the burden of skin fibrosis. And so we choose 17 sites of the body and we squeeze the skin and we decide whether it's normal, 0, mild, moderate, or severely thickened, grade 1, 2, or 3. And so theoretically, a patient could have a maximum skin score of 51. In practice, when patients present with diffuse scleroderma, the skin score is usually between 20 and 25 when we start therapy. And there are standard approaches now to do the skin score, to train to do the skin score, and it's a useful endpoint in clinical trials that has been shown to be informative in demonstrating treatment benefit. But it's always been a question of quite how much our patients are improving or benefiting from the standard immune suppression that we're using. And really perhaps the best real world evidence that we have comes from the European observational scleroderma study. So this was a study that we led from the UK. Ariane Herrick coordinated this from Manchester. We were very heavily involved and put many of our patients into this trial, which was recruiting across Europe and recruited more than 300 patients with early diffuse systemic sclerosis. And these patients went on to one of 4 treatment approaches. As you can see, they went on to methotrexate, mycophenolate, cyclophosphamide, or indeed they may have elected to go on to no immunosuppression. And then they were followed up for a year, and we worked out whether the skin score had stabilized or improved according to the treatment groups. Now, what I should say is that this is an observational cohort design with propensity scoring, so statistically adjusted for the baseline factors that we know can influence skin outcome. And so what we see here is the modeled improvement in skin score over 12 months. And you can see that on average, those on methotrexate or mycophenolate improved by 4 skin score units over 12 months. This is important because the baseline skin score, as you might expect, was on average around 21. And this meant that this did reach the threshold of significant benefit at a group level of 20% improvement and 4 skin score units. So those immunosuppressive drugs do seem to work, at least to some extent, because those patients that were on no immunosuppression, although they did show overall some improvement, we know that this can occur as part of the natural history of skin change in scleroderma, that in fact that group on no immunosuppression didn't do better. In fact, they had a higher mortality, as you can see here. And in fact, it looks like that any of the immune suppressive drugs improve outcome and survival, but immunosuppression does also have at least modest benefit for the skin. But that is relatively modest benefit. It's certainly way less than we would like to see in our patients. And that really is what underpins the thought about perhaps more intensive immunosuppression would give greater benefit. And this was the rationale behind the concept of stem cell transplantation for systemic sclerosis, as it has been used in other autoimmune diseases. The rationale being that if you could really give very potent immunosuppression to such a level that the patient would not normally survive because of myelosuppression, but you rescued them with autologous stem cells that you'd harvested before the high-dose chemotherapy, you may see a greater benefit. So there have been 3 clinical trials that have tested whether this very aggressive therapy might be better than just giving more standard approaches, such as monthly cyclophosphamide infusions for 12 months. So 3 trials have been published. And in fact, all 3 trials showed that there was a long-term survival advantage for those patients that had the stem cell transplant compared to those just receiving 12 months of intravenous cyclophosphamide. But at an individual patient level, you can really see the benefit. And I just share with you this case history. This is Sarah. She was very happy for me to share her case history. I presented her a few years ago now at the British Society for Rheumatology Heberden round. But she's very illustrative because Sarah was a patient I'd known for many years with mild systemic sclerosis. As you can see, the skin score plotted on the y-axis over time here. She really did very well for many, many years. And then around 2015, her disease suddenly got a lot worse, more vascular problems, digital ulcers requiring treatment. But the main thing was the skin sclerosis progressed over just a few months. And you can see that it rose to 30 and then continued to get worse despite treatment with full-dose mycophenolate mofetil. She'd also had an immunological change in her disease because she developed an anti-RNA polymerase antibody, an antibody often associated with severe skin disease. And this really led me to think that she would be a highly suitable patient for a stem cell transplant, and that's what she had. And you can see that quite rapidly after the stem cell transplant, she dramatically improved in terms of skin, and this has continued up till her recent follow-up. And she's really back to where she was perhaps a decade or more earlier. So there's no doubt at an individual level for skin, immunosuppression can be certainly improved with a stem cell transplant, but this is not a treatment without hazard. And we know this from the largest stem cell transplant trial. This is the data from the ASTIS trial that was published in 2014. And what this very nicely shows is that a stem cell transplant can be associated with longer term event-free survival or overall survival. So you live longer if you have a stem cell transplant overall compared to cyclophosphamide for a year. But that benefit only kicks in at 2 years. And this is because the treatment itself has a high mortality, up to 10% treatment-related mortality in this study. So you really do have to choose your patients carefully when you're moving forward with this sort of aggressive approach. It does work on more than just skin, though. You can see here, not only was there significant benefit for skin, but also for the HAQ Disability Index and for lung function. Some things don't get better. Overall, renal function was worse, significantly worse, after the stem cell transplant because of the sort of challenges to the renal system of the chemotherapy and all of the other aspects of the treatment. But it is a treatment that's helpful, and this was confirmed in the Scott trial that used a slightly more aggressive myeloablative conditioning approach. And again, it showed that there was benefit, but again, you only really see that benefit after about 2 years. So cyclophosphamide works, but that long-term benefit you get from the stem cell transplant is apparent. So this is certainly an option for patients, but only for those patients that are going to survive the process and have severe enough disease to warrant that very aggressive approach. So most patients don't fall into that group. And as well as skin fibrosis, we have to deal with lung fibrosis. And here we can summarize the lung complications of the disease, mostly lung fibrosis. We see some patients, of course, with pulmonary hypertension, as I've shown, but lung fibrosis is the commonest lung complication, and it usually has an NSIP pattern with a relatively preserved lung architecture. We again have an evidence base to support the benefit of treatment, but it's very important to choose the right patients to give that treatment to, because we know that just as skin disease sometimes stabilizes or improves on its own, that if patients have very mild lung disease, it can sometimes remain stable and not impact on their long-term survival, as you can see here in some data that we published in conjunction with the Brompton Hospital. But as soon as more than 20% of your lung is affected by fibrosis, you see a major impact on long-term survival. And when you're have an extent of disease of more than 40%, this is catastrophically severe. You can see only about 30% of the patients being alive after 5 years. So this is very important in terms of identifying which patients to treat. And we use a staging approach that was published in this original description that has been now validated across several independent cohorts. Whereas rheumatologists, we assess the patient's CT scan. We think that all patients with systemic sclerosis at risk of lung fibrosis should have an HRCT. And some patients clearly will have very trivial disease, and these patients we will just watch and observe for any future decline. But some patients will obviously have extensive disease, and these will have whatever treatment we have available, and certainly we would consider these for initial immunosuppression. But around 2/3 of patients can't easily be categorized like this. And in those patients with what we call indeterminate disease on CT, we did make our treatment decision based on lung function with a threshold of FVC 70%. So if the lung function is impaired with an FVC of less than 70%, those patients are very likely to progress or have extensive disease, and those patients will be treated. But it is important to remember that all patients, of course, start off with no lung fibrosis. And so even though we may categorize some of our patients as mild, we still need to be very vigilant for that early progression, because as we have more treatment options, we should be intervening earlier to try and prevent patients getting advanced and severe disease. What is the evidence base for the standard treatments that we've been using for lung fibrosis? Well, there's actually a little bit more robust evidence for cyclophosphamide and immunosuppression as a treatment for lung fibrosis than there is for skin, because we have some placebo-controlled trials. First of all, the first scleroderma lung study, SLS1 from North America. So this was a trial of 1 year of oral cyclophosphamide compared to placebo, and it met its primary endpoint at a year. So there was less decline in patients who were on cyclophosphamide compared to true placebo. And there were some encouraging changes in secondary endpoints related to symptoms and skin disease, in fact. So that was encouraging, but it was a very marginal change. It was only a 2.5% advantage for patients on cyclophosphamide. But the patients were followed up for 2 years. And what you can see is that by 18 months, those patients that had been on cyclophosphamide had continued to improve. And by then, there was really quite a meaningful benefit of around 7% difference between the patients who had cyclophosphamide and placebo. So I think definite evidence that cyclophosphamide works. But at the same time, we conducted a trial of intravenous cyclophosphamide in the UK, and this showed a very comparable treatment benefit of around 5% advantage at 12 months, but with a better side effect profile, as you might expect, compared to oral cyclophosphamide. So this has been very much our standard approach to treating patients with lung fibrosis and systemic sclerosis, until we got the data from the second scleroderma lung study. But while we were using these immunosuppressive treatments, there was always a question about whether they were truly antifibrotic or were they just treating this sort of inflammatory component of the disease. But again, from the first scleroderma lung study, there were some very elegant quantitative CT analyses that are summarized here that show that absolutely clearly the patients who were on cyclophosphamide had less progression of their lung fibrosis, shown here over 12 months. So you can see here a patient on cyclophosphamide showing improvement, less dense fibrosis. So the densest fibrosis shows up as blue on this computerized CT analysis. Fibrosis itself shows up as yellow. The patients on cyclophosphamide showed some improvement. Those on placebo showed worsening, and this was statistically significant at a group level, but you can see very impressive for individual cases. So this really increased the level of enthusiasm for immunosuppression as a treatment for scleroderma ILD, and this led to the second scleroderma lung study, SLS2, and the data for this were really designed to show whether oral MMF might be better tolerated and as good as oral cyclophosphamide. So you have to believe the SLS1 that cyclophosphamide is superior to placebo, and then what these data nicely showed was that you get exactly the same benefit from mycophenolate mofetil that you get from cyclophosphamide, but with a much better safety profile, particularly hematological toxicity, as you can see here. So patients with cyclophosphamide having a much higher rate of particularly leukopenia and platelets, and in fact having more deaths than the mycophenolate arm during the period of follow-up. But we've now been able to move on from just using immunosuppression for our patients with scleroderma lung fibrosis, because we have a licensed approved therapy for lung fibrosis, an antifibrotic therapy. And this has been really in being able to import the treatment that is licensed for idiopathic lung fibrosis, or at least one of the drugs that's licensed for idiopathic lung fibrosis as an antifibrotic, that's nintedanib. So this blocks profibrotic pathways and is antifibrotic for idiopathic lung fibrosis, with around a 50% reduction in progression over 12 months for IPF. And exactly the same amount of benefit was seen for scleroderma ILD in the census trial in terms of the proportion of decline. So a 44% reduction in progression of the scleroderma lung fibrosis in this very typical large lung fibrosis population. But of course, because scleroderma lung fibrosis is much less progressive than IPF, the numerical decline was substantially, or benefit was substantially less. So just 41 mils benefit at 1 year. So this is really sort of marginal in terms of absolute change in FVC. But this trial was very much a real world study, because it allowed patients to be on mycophenolate mofetil, that we already know is a treatment that can be helpful for scleroderma patients. Not all patients were on MMF. In fact, around half of the patients were on mycophenolate mofetil in this study. It wasn't formally stratified or randomized, but that was the way the data fell out in the end. And this was very helpful, because you can see very nicely that those patients who are on neither MMF nor nintedanib had the biggest decline. And here you are starting to see quite a meaningful decline of 120 mils at 1 year. Those patients who are on both nintedanib and mycophenolate had the least decline of only 40 mils. So this does start to tell us that not only can you combine nintedanib and mycophenolate mofetil, but you probably get extra benefit by using 2 drugs. And it makes sense because you're treating 2 different, perhaps, facets of the disease. And you can see here just how those lines separate. So you do get benefit of nintedanib alone, you get benefit from mycophenolate mofetil alone, but if you have the 2 together, you've shifted the curve very nicely in an upward direction. So our current approach to managing scleroderma lung fibrosis at the Royal Free is to try and detect patients as early as possible, to really focus on lung function, antibodies, clinical phenotypes, so we identify those patients most at risk of severe lung fibrosis, to stage them when they have established lung disease as to those that have extensive or mild disease, and then to treat patients that we're worried about in terms of progression. And these are the treatments that we use based on the evidence. So mycophenolate as a first-line treatment, cyclophosphamide we would consider in patients who've progressed, or sometimes increasing the dose of MMF. We have licensed antifibrotic drugs now, of course, including nintedanib, but also important to treat other aspects of the disease that may be contributing to progression of the lung. Reflux disease should be treated very aggressively. And of course, infection may need treatment. We treat many of our patients with prophylactic antibiotics. And of course, oxygen can give great symptomatic benefit. But patients do progress, and we clearly have significant unmet needs still. And so I wanted to move to the next part of the talk to really talk about what we hope might be emerging as better treatments for the future. And there's been a lot of progress really in, I think, understanding systemic sclerosis. So here's another of our patients with the disease. Again, very happy for his photograph to be used to educate physicians about the challenges of systemic sclerosis. Unfortunately, this gentleman died of lung fibrosis after a number of years of follow-up. But we have made progress over the last few years, I think, in understanding the pathology and pathogenesis of systemic sclerosis, and also in understanding how we can best predict complications and design our clinical trials. And this has allowed us to start to move to an era where we can not just do trials of very broad treatment approaches like stem cell transplant, but do trials of much more targeted therapies to try and perhaps gain extra benefit with less toxicity. And I'm going to just show 3 examples of drugs that have been shown in clinical trial to be very encouraging for skin or other aspects of the disease that really do start to target in a more precise way some of what we now understand are the fundamental pathologies of systemic sclerosis. So we know that systemic sclerosis is an autoimmune disease, and we now have very sophisticated ways of looking at the immune system in systemic sclerosis. And here's some data from a recent collaborative study that just looked at a small number of patients, but these were patients that were biopsied and studied on their first visit before they'd had any immune suppression. So these were patients with early diffuse scleroderma, where we really had an insight into what was the immunological drive of the disease. And you can see there is clear evidence of T cell activation, increased IL-2, reduction of immunosuppressive cytokines like IL-10, and really very much a molecular signature of T cell activation, as you can see here. So that makes sense really to try and target the T cells perhaps more specifically in these patients. And one of the ways that we can target T cell activation is to use a drug that targets T cell co-stimulation. And a drug that we have already available in clinical practice for that is abatacept. So this is an approved therapy for rheumatoid arthritis. And a controlled clinical trial was completed and published last year that tested in 86 patients, randomized either to placebo or to abatacept over 12 months, whether this might be a useful treatment for their scleroderma. Now, the primary endpoint in this trial was the skin score. And here you can see on the right upper panel, the change in skin score over 12 months in the study. So this showed a trend of benefit overall. So patients who are on abatacept did show greater improvement than those who are on placebo. But again, it emphasized, as we'd seen in the ESOS trial, that patients can improve even if they're on no immunosuppression at all. Well, what was interesting is when we looked in more detail at the characteristics of the patients, those patients that had inflammatory changes on the skin biopsy at baseline, shown on the left upper panel in purple, these were the patients who really didn't show any improvement on placebo, but they dramatically improved on abatacept. So what this told us was that immunosuppression is certainly helpful in this group of patients for skin, but only probably if you've got an immune cell population in the skin driving the disease. So it's not all that we need to treat the skin, but it's helping in some patients. But what was very interesting was that all patients, whether or not they had inflammatory changes on the skin biopsy, showed a significant benefit in another clinically meaningful endpoint, and that's the HAQ Disability Index. So really a measure of disability, but in particular of upper limb function. So this was encouraging because this wasn't just a trend of benefit, it was a highly statistically significant change, and something I think that could be taken forward. So this was a phase 2 clinical trial, so we'd really need to see a phase 3 trial to get really convincing evidence. But I think it's very encouraging and at least tells us that immunosuppression may be improving not just the skin, but also other aspects of the disease, and that abatacept might in particular be helpful for the musculoskeletal challenges of our early diffuse scleroderma patients. So another product of our translational research has been the use or development of strategies that target interleukin-6. So some years ago, in fact, in our center, we became interested in the observation that there was a group of patients with systemic sclerosis that were doing very badly with standard treatments. And they all often had features of high acute phase, so elevated ESR, elevated C-reactive protein, elevated platelet count in the peripheral blood. They often had diffuse skin disease, and they seemed to be refractory to our standard approaches of immunosuppression with drugs such as mycophenolate mofetil. And we measured the IL-6 levels in a series of these patients, and what we showed over a period of time, as you can see here, is that those patients that had high levels of IL-6 had a significantly worse survival. So this was just a small observational cohort study of 40 patients, but you can see those patients that had high IL-6 had a worse outcome. So around the same time, we did some collaborative work with colleagues at the Royal Brompton Hospital in London, and we showed that, interestingly, the IL-6 was not only predicting long-term survival, but it was predicting the progression of patients' scleroderma lung fibrosis, but it was predicting progression not overall in those patients with established lung fibrosis, but particularly in those patients with early phase with preserved lung function. So those patients that we might normally not be treating even with immune suppression were benefiting, and those that had high IL-6 were showing significant progression. So all of this led to interest in designing a clinical trial that would test whether blocking interleukin-6 would be helpful for scleroderma and might benefit the skin and might benefit other aspects of the disease. So we were very pleased that Roche, who have the marketing authorization for tocilizumab in the UK, were very interested to do a clinical trial of tocilizumab in patients with severe scleroderma. And this led to the phase 2 clinical trial, which was Fascinate, and this was performed a few years ago now. And these were the primary data. So the primary endpoint was skin. And what this showed was clearly there was an advantage to those patients that were on tocilizumab compared to placebo. It didn't quite reach statistical significance at 1 year, but it was very encouraging. At the same time, a molecular biomarker that correlates with skin involvement did show significant benefit at 6 months in this study. And more impressively, there was clearly, as we might have expected, a slowing of the progression of lung fibrosis in this group of patients who hadn't been selected for lung fibrosis, but clearly were at high risk because they had early diffuse scleroderma. So the phase 2 trial data were encouraging. This led to the phase 3 trial, the FOCUS clinical trial. Again, this was designed to look at the benefit on skin, but with very careful observation also of the lung function, recognizing the potential benefit of blocking IL-6 in those patients with progressive lung disease. The skin findings really replicated what was seen in the phase 2 trial, a trend of benefit, but the lung function impact was really very meaningful, as you can see here. And when you particularly looked at those patients, which is around 2/3 of the patients that actually had some lung fibrosis on their baseline CT scan, you can see quite remarkably how being on tocilizumab compared to placebo impacted on the change in 1 year. Those patients who were randomized to receive tocilizumab essentially had completely stable lung function at 1 year. those patients who were on placebo had a very significant decline of around 6.4%. So this was highly statistically significant. It was a decline of something around 240 mils, so much more than had been seen, for example, in the census trial of nintedanib. So this was encouraging. Even more encouraging was the fact that we did quantitative CT analysis in the trial. And here you can see some examples of patients that either received placebo or tocilizumab. So at baseline, there was clear evidence of lung fibrosis, which significantly worsened on these two patients on placebo, and significantly improved in those patients who went on to tocilizumab. But this could be analyzed at a group level using a very sophisticated computerized quantitation, as you can see here. And the bottom line really was that for all patients, in fact, with lung fibrosis at baseline, the lung fibrosis got better if you were on tocilizumab, or it got worse if you were on placebo. And this was convincing enough to regulators to, in fact, give recent approval. So the FDA has approved tocilizumab for the treatment of scleroderma lung fibrosis to reduce the rate of lung function decline. And I think this is a landmark because, of course, now we've got two approved therapies that work in different ways and give us more treatment options for our patients. The final strategy I'd like to just introduce is the thought of perhaps targeting the innate immune system in a little bit more detail, and really focusing on macrophage biology, because it's emerged from a number of studies that activated macrophages almost certainly have an important role in driving the progression of systemic sclerosis in the skin and maybe in the internal organs. And that when we looked in a collaborative study here with colleagues at Imperial College, you can very clearly see an activated profibrotic macrophage phenotype in systemic sclerosis patients. And you can induce this phenotype if you treat monocytes with a combination of interleukin-4 and interleukin-13. So this raised the possibility of maybe if we targeted macrophage activation or polarization in vivo, we could see benefit. And we can test that using a monoclonal antibody that blocks those same two cytokines, interleukin-13 and interleukin-4. And a clinical trial was conducted of this very clever monoclonal antibody that is bispecific. So it's a monoclonal antibody that blocks both IL-4 and IL-13 at the same time, and so would be predicted to influence macrophage activation and polarization, and really try and reduce the number of profibrotic macrophages. So this study was completed and was published last year. And this was a very encouraging study because, again, it met its primary endpoint. It was a phase 2 clinical trial. The primary endpoint was skin. So it did seem that these patients who were randomized to receive romilcomab showed a significantly better improvement in their skin compared to those in the control arm. And that was even more significant if you focused on those patients with the most severe skin disease, with a skin score of over 15. But like the census trial, this had been a real world approach to trial recruitment because patients were allowed to be on background immunosuppression. And just as in the census trial, about half of the patients were on background either methotrexate or MMF, and about half the patients were on no background immunosuppression. And this allows us again to look and see whether the combination of a biologic with immune suppression is giving extra benefit. And it does seem to be the case because, again, those patients who are on no treatment, essentially just on placebo, no background immune suppression, showed a skin score improvement at 6 months of 1 unit. So exactly aligned with what we saw in the ESOS trial in those patients not on background immunosuppression, where it was 2 units at a year. But those patients fortunate enough to be on background immunosuppression and on romilcomab had a nearly 6 skin score units improvement. So it does seem, again, that we're seeing if you add treatment to that background immunosuppression, you see more benefit. So just to summarize a lot of the trials that have emerged over the last few years, and it has been a very exciting time really to be doing clinical research in systemic sclerosis, because as you can see in this table, summarizing some of those trials, we've had the census trial, which met its primary endpoint and led to approval of nintedanib for systemic sclerosis associated ILD. We've seen the focus trial, which although it missed its primary endpoint of skin, was in fact sufficiently impressive to get regulatory approval again for its impact on lung function in systemic sclerosis. I've shown you the encouraging data from the phase 2 trial of abatacept, suggesting this may be very helpful for musculoskeletal symptoms in systemic sclerosis. And in fact, we've had 2 clinical trials reported recently. I've just shown you one of those, the romilcimab study, but an autotaxin inhibitor trial also targeting the IL-6 pathway also showed statistically significant benefit when added to on top of background immunosuppression. But as you expect in clinical research, not everything has been positive. We had a very negative trial for a PPAR agonist, which had shown very great promise in preclinical models, but when we used it in clinical trials in scleroderma, it didn't improve skin at all compared to background therapy. It's still looking very promising for NASH, for liver fibrosis, so it may still emerge as a very useful antifibrotic drug. And more recently, we had the very disappointing results from the phase 3 trial of lenabasum. So lenabasum was an endocannabinoid, a cannabinoid agonist that looked very promising in the phase 2 trial, but in a large phase 3 trial, again, failed to show superiority to background therapy. So it's not that the patients didn't get better, but we couldn't show benefit of adding this lenabasum on top of immunosuppression. So I just wanted to finish to say that, unfortunately, even with these advances, we're still perhaps showing more benefit at really slowing the decline or progression of decline in scleroderma lung function, but we're not sort of reversing the changes effectively. And we do need to think of how can we actually sort of in a more positive way improve the quality of life of our patients. I just wanted to share with you one approach that we're using because it's sort of something that's a little bit different, I think, particularly for rheumatologists, and that is autologous lipotransfer. So this is essentially a cellular therapy, and it's shown in schematic form here, but essentially you harvest fat from the proximal body, from the abdomen or the upper thighs. So it's like a liposuction approach. You then centrifuge the fat to get rid of the sort of debris, and you then have a cell-rich fraction, and you can inject this in a very delicate way in affected areas in systemic sclerosis. And where we've really used this with our plastic surgeons is to treat the orofacial aspects of scleroderma. Now, this has started off really as an attempt to give a cosmetic therapy to try and improve facial appearance, which is such a burden for our patients with established systemic sclerosis. But what we were very struck by when we did this work was that in fact the patients seemed to be getting much more benefit than just a better facial appearance. And so we published our series. This is the largest series so far of this approach to treatment of 62 patients. And here you can see just one of those patients with the before and after changes. And of course, the benefit may be relatively subtle, but it makes an enormous difference to patients if you can reverse some of these connective tissue losses that occur in established scleroderma. But what we were very impressed with when you looked across the patient cohort was that when we very objectively assessed measures such as mouth opening, sicker symptoms, the aesthetics, as they impact on quality of life, you can see that there was a highly statistically significant benefit post-operatively that was reasonably durable, particularly after more than one fat transfer treatment. So this was open label examination, and we're now doing a controlled trial to really see whether we can really establish this as a treatment that gives, I think, great hope to for our patients in managing difficult aspects of the disease. So what I hope I've shown you in the presentation today is that we have moved forward in our treatment approaches to systemic sclerosis, but also in parallel, we've moved forward in our understanding of systemic sclerosis biology. And it really is a case of we may not understand the cause of systemic sclerosis or the precise disease mechanism, but we understand enough now to be able to start to make rational choices about which drugs to test in clinical trials and how perhaps to combine those drugs to get maximum benefit. So I think that is an encouraging place to be for the future. But what I would like to really sort of emphasize is that even though we've seen improved survival in our patients, even though we've now got treatments for scleroderma renal crisis and for pulmonary hypertension that I haven't really focused on today, even though we've now got 2 approved drugs for scleroderma lung fibrosis, we're still seeing that many of our patients are succumbing to the disease. They're living longer with the disease. But of course, as they're surviving longer with systemic sclerosis, this means that the non-lethal burden, digital ulcers, gut disease, calcinosis, fatigue, and so on, is even more pressing. And so we really need to sort of be thinking more about how we can improve symptoms and quality of life. We've got stem cell transplantation, which is an evidence-based treatment, but again, only suitable, I would suggest, for a small minority of patients. We would suggest in our practice, perhaps only about 5% of patients we might consider for this approach. And so we do need to do more. And I've shown you, drugs that are moving through clinical trials. We've got other drugs that are in development. And I've also I've shown you one example where we need to think about perhaps more imaginative or different ways of approaching our patients, particularly regenerative medicine approaches. I showed you the benefit potentially of autologous adipocyte transfer, but I think that we've got a lot more potential options or ways of harnessing progress that we could apply to our systemic sclerosis patients. So with that, I'm going to finish now, and I'll be delighted to take any questions. I'd just like to acknowledge, of course, that we've got a fantastic team of scientists and physicians looking after all of our patients at the Royal Free. We get a lot of funding for our research, and we collaborate a lot nationally and internationally. And it's a real pleasure to have given this presentation to you today. So thank you very much for your attention.